Good afternoon. Welcome to Grand Rounds today. Please remember to sign the attendance record at the back of the auditorium, and then also please remember to fill out and return the program evaluations, and most importantly, please give the CME committee any ideas that you might have in regards to future topics or future speakers you'd like to hear. We will not be having a Grand Rounds program next week, and then we will reconvene on the 5th with Dr. Scott Vogelsang from the University of Iowa, showering us with rheumatology pearls. Today, it's my pleasure to introduce Dr. Grant Goldsberry. Dr. Goldsberry is a board-certified radiologist. He has been a member of the radiology departments at McFarland and MGMC since 2011, and he has kindly accepted our invitation today to update us on an evolving field, or the evolving field of breast imaging, and please join me in welcoming Dr. Goldsberry.
Thanks everybody for joining us today. So basically I thought this was a relatively timely discussion to have. Basically it boils down to every other week there's another society coming out with their recommendations on how we should be screening women for breast cancer. There's multiple different parameters or algorithms for how to screen patients. And I'm basically just going to run through why we're doing breast screening, what the new upcoming modalities are, and what I think are the best ways to screen women for breast cancer. So again, this is the main question we'll start with, is why do we screen for breast cancer? Obviously, the idea is to detect early, and by detecting cancers early, our ideal is to have better treatment outcomes. This is a general overview of what the estimated effect is of breast cancer screening in the U.S. from 1989 onward, while including the always improving treatment options for breast cancers. So as you can see, we'll look back to 1989 through 2012. It's estimated that we've saved anywhere from 230,000 to 370,000 deaths from breast cancer by screening, and also with the latest advancements in treatments for breast cancer. As you can see, as we move on to 2015 and 2018, those numbers continue to improve. So the total number of patients that we're able to save from breast cancer death continues to accumulate. And breast imaging is important because breast cancer is so common. It's one of the most common cancers that people have in the United States, so any improvements in screening, any improvements in treatment can have dramatic effects over the whole population for the number of women that you can improve outcomes on. This is kind of a historical look back on where we've been and why we're trying to improve our screening. With 2D mammogram, which is traditionally before we had the 3D mammograms and the tomosynthesis, was just a two-dimensional image of the breast in two views. In women that have the least dense tissue, and I'll discuss breast density later on in the program today, we were pretty good catching approximately 8 out of 10 cancers on mammograms. But as women had more dense breast tissue, the number of cancer detections dramatically decreased. So when you see these two numbers, you know we have to find a better way to screen women, especially those with dense breast tissue. So originally, mammography was the typical screen films that you hang on the light board. The first technological advance was moving to digital mammograms, which improved cancer detection. And now the latest iteration is tomosynthesis, or 3D imaging, which has also continued to improve our cancer detection and the size of cancers that we're able to see. This is a study out of Oslo that looked at the sensitivity for detecting breast cancer of 2D images, the 2D images with the 3D tomosynthesis on top of it. And then the last column is actually acquiring the tomosynthesis images and then recreating two-dimensional images. And as you can see, if you look at the first column, we are detecting 55, 54% of breast cancers. you move up into the last two groupings, and we've been able to improve the sensitivity for detecting cancer from the mid-50s up to 70%. The nice thing about the synthesized 2D image is you're able to limit the radiation exposure that occurs with mammograms. This just reiterates 3D mammogram over 2D mammograms. It has the benefit of improving cancer detection. So this study estimated that there are 27% more cancers picked up, and more importantly, it's not just low-grade, potentially incidental cancers that you're picking up, but those invasive cancers also have a significantly increased detection rate. The other plus with 3D mammogram over 2D is you not only pick up more cancers, but you have fewer callbacks. So those of you that have had a mammogram know that we can read an initial screening mammogram and potentially request additional images. And in a lot of those cases, it turns out not to be cancer, but obviously that causes stress for the patient having to wait that length of time before the repeat or recall examination occurs. This is a Johns Hopkins study that basically just reiterated the point I was just making on the previous slide, where 2D mammograms in this particular study had a 10 to 11% recall rate. In a 3D study, that recall rate went down to 8%. And that does mimic what we see here locally as well, that our recall rates did significantly improve with the 3D image. The main reason for that is you can just get, when you're taking a three-dimensional object and compressing it down to a two-dimensional image, there's going to be overlap of the various tissues that can masquerade as a mass or other abnormality that we need to further address. Looking at radiation dosages is obviously important. Mammograms are still low exposure. The main point of this slide is on the far left-hand side of the screen. That's the 2D dosage that a patient would get. So that's been the typical dosage from a 2D mammogram. The far right-hand side, the red column, is the dosage of radiation exposure that you get with the 3D tomosynthesis image combined with a synthesized 2D image, and that the brand terminology for that is the C-view. So you can see that there's minimal increase in the dosage doing it that way. There is a fairly significant increase if you combine both the 2D with the 3D. Looking at lifetime mortality risk from the radiation exposure from mammography, these numbers are just reinforcing the idea that it's a low exposure, low risk procedure. Obviously, the risk of dying from breast cancer is dramatically higher than this extremely small risk from the radiation exposure over the years from repeated mammograms. The big question these days is when to start screening. There are numerous studies that will say you can wait till 50, you can start at 40, you can start at 45. So there's a lot of confusion over what the appropriate age is to start screening. The main thing I want people to realize is there's mortality reductions that go into the screening paradigms, but then there's also a value proposition that goes into the screening paradigms. The highest percentage mortality reduction happens when you start screening annually at age 40. So the biggest benefit of screening and mortality reduction, again, is from women starting screening at age 40. You can look at these other two paradigms, the biennial screening starting at 50, and you can compare the two. There's a nearly 40% mortality reduction with the annual screening, and it falls all the way off to 23% when you do biennial screening starting at age 50. This is just a different way of looking at that same data. And again, you can see at the top column is the most intensive yearly screening. You get a mortality reduction of nearly 40% by doing that annual screening starting at age 40. As you continue to drop down to less frequent screening in a narrower age group, the mortality reduction dramatically falls off. And the far column just shows the number of life years gained per 1,000 women screened. And that's just emphasizing the point that obviously if you detect a breast cancer in a 95-year-old, the potential number of years that you're going to save by detecting that cancer is going to be much less than picking up a cancer in a 40-year-old woman that has potentially a 40 or 50-year life expectancy. These two slides, again, are just breaking down the data in similar formats, but again, it just reproduces the idea that annual screening mammography has the highest mortality reduction and the most life years saved per 1,000 women screened. Keep in mind, at that top column, this is annual screening. You look at that 40 to 49 group, it's 1.3 lives saved per 1,000 screened. If I jump to this next slide, you can see each of the columns drops down. So again, the biennial screening, the reduction in mortality decreases by doing the every other year rather than annual screening. So this is one of the recommendations that's been made, is to start at age 50. There are numerous other recommendations, cancer societies that have come up with differing recommendations. Again, the key take-home point is this particular recommendation is combining the outcomes data with the mortality reduction with a cost analysis. So that's a perfectly appropriate discussion to have. Are we spending too much money on screening when we have a limited number of dollars to spend on healthcare? But I just like to reinforce the idea that it's a value discussion, not an outcomes discussion. Annual screening mammograms at 40 has the highest mortality reduction. The latest iterations or advancements in the screening protocols is, instead of looking at a overall population-based screening, we're really trying to individualize our screening to an individual woman and her risks. So some women may need more intensive screening, other women may need less intensive screening, and I'll go through and kind of outline the latest updates and what our recommendations are. Risk factors are obviously a key driver of the different screening parameters. There are personal and behavioral risk factors, so age of onset of menstrual cycles, pregnancies, obesity, alcohol use, all are part of the risk factor calculation. There's obviously prior history of either pre-malignancies or breast cancers, radiation exposure, such as the woman had lymphoma or some other type of cancer that had radiation exposure to the chest. Then we also look at family history, so relatives that either have breast cancers, ovarian cancers, and the mutation status that they may have, the genetic factors that impact breast cancer. The most recent risk factor that's been identified is breast density, and that's kind of an emerging area of research. We're really trying to understand the full impact of breast density and how that impacts not only detection of breast cancer, but your risk for developing breast cancer. Just a quick overview of what breast density is. When women are labeled as having dense breast tissue, those are women that tend to have more fibrous and glandular tissue and relatively less fatty tissue. That tends to be somewhat based on age. So younger women tend to have more dense tissue and older women tend to have less dense breast tissue, but there obviously is variability across the ages as well. As radiologists, we classify them into 4 different categories. So the entirely fatty is what would be considered the least dense, and as you move across, we're going into the extremely dense category. And again, you can see that white kind of snowstorm appearance. That's the glandular and fibrous tissue of the breast that makes it more difficult for us to not only detect breast cancer, but also increases the risk of breast cancer. On mammograms, cancers show up white. So as you can see, if you have more of that white background appearance, you're going to be less likely to detect a cancer until it's increased in size. The way I typically explain this to patients is, if you look at a stream with some rocks in the bottom, you don't stir the water up, you can see down to those rocks really easily. You take a stick and stir up all the dirt in there. The rocks are still there, but you're just clouding your ability to see the rocks at the bottom. General breakdown of women and how the breast density is categorized overall, the whole population. So approximately 50% of women have what are considered dense breasts, and those are the extremely dense and the heterogeneously dense, and approximately 50% are considered non-dense. Again, this tends to be skewed to the younger population. A higher percentage of them are classified as having dense breast tissue, and as you age, a higher percentage are classified as having fatty breast tissue or non-dense. This is just the nomenclature that we use. Again, it's the 4 density categories. C's and D's are what we would consider as having dense breast tissue, and those are the ones that are most at risk for breast cancer and also have the highest incidence of quote-unquote missed cancers on a mammogram just because they were obscured by the tissue. An important thing to look at is the masking that happens with the breast density, but this demonstrates the relative risk of having dense breast tissue. So what this is comparing is if you take that grouping of the least dense, that 5% and lower grouping, and compare them across the A, B, and C and D categories. If you get into the most dense category, category D, they have a 4.5 relative risk increase of breast cancer. So this isn't small, minute increases in the risk of breast cancer. It's dramatic 4-fold, 4.5-fold increase of breast cancer just simply by having dense breast tissue. An important thing, again, is getting back to that idea that 50% of women have dense breast tissue. So while age and mutation carrier status are obviously important factors, the number of people that have the BRCA gene mutation is a relatively small number of people compared to the number of people that have dense breast tissue. So attributable risk is actually very high for breast density just because of how common it is in the population. This is one of those things where it's intuitive, but there is data to back it up. You have a small cancer, it's less likely to be metastatic at the time of presentation, nodal involvement, bone involvement, other sites where breast cancers can go. So it makes sense, but there is data to back it up that if we detect cancers earlier, they're less likely to be metastatic, more prone to having good treatment outcomes. Tumor behavior, again, women that are young that develop breast cancers, they tend to be a more aggressive behaving cancer. Women in the older age group, when they do develop cancers, they tend to be less aggressive. So again, you're seeing the kind of the catch-22 that happens. Young women have dense breast tissue and tend to have more aggressive cancers. So there's a doubly good reason why we need to detect cancers earlier and have newer ways of imaging the breast and detecting cancers. So this jumps into some of the newer options for screening. 3D mammography is relatively widely available at this point in time across the country. Both the hospital and the clinic here in Ames exclusively image with the 3D mammograms. Several years ago, I did a talk with screening breast ultrasound, so I'll kind of run through some of the highlights of that. And also, the emerging technology now is screening breast MRI. Again, that has a high utility in both high-risk women and women with dense breast tissue. This was a Korean study that, again, just looks at cancer detection rates. So we have the 3D mammogram grouping, the more traditional 2D mammograms, and then also the newer modalities with MRI. So you can see that of the total cancers that were detected, and again, these are women with dense breast tissue, 2D mammograms in this particular study picked up about 63% of the cancers. When you added the tomosynthesis or the 3D, that picked up an additional 13% of the cancers in the study. When you added MRI on, that found an additional 23% of the cancers in the study. So 2D obviously picks up, in this particular study, it actually did pretty well where it picked up 2/3 of the cancers, but then you can see the interval increase of adding both the tomosynthesis capabilities and the MRI capabilities. Important thing to realize too are the MRI detected cancers. They aren't simply low-grade DCIS type cancers. In this particular study, 60% of the cancers were invasive cancers. So these are what I would classify as important cancers that have a high propensity to spread if they aren't detected at an early stage. This is just a sample image of what we're able to see with tomosynthesis. So if you can see this particular area here, so this is a woman that has dense breast tissue overall, but if you take a look at this small area right here, the cancer is probably this teeny, 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 tiny little cancer in the center of it, and you can see that spoke wheel appearance kind of shooting out on all sides. The tomosynthesis really allows us to see when that cancer starts tugging on the support structures of the breast, and it's this we classify it as architectural distortion that happens. So this was a very small cancer that the tomosynthesis allowed us to pick up in a woman with dense breast tissue. It was a 1/2 centimeter size cancer, and thankfully in this case there was no lymph node involvement, so this woman should have a great prognosis. Several years ago, here in Ames, we added screening breast ultrasound, an automated form of screening breast ultrasound. And this was again tailored to women with dense breast tissue or women that have had prior breast implants. This is an example of, again, a woman with dense breast tissue. No malignancies were detected on the mammogram. Subsequently went for the screening ultrasound, and this right here is what a cancer looks like on an ultrasound. So you can see it's a little bit darker than the surrounding tissue. Again, this is a cancer that it was surely somewhere on the mammogram, but it's just hidden behind all the dense tissue that was noted on that study. This was about a 1 centimeter cancer. Again, it was an invasive cancer, but again, thankfully in this case, no lymph node involvement. So again, this just reinforces the idea small cancers are less likely to show lymph node involvement and other sites of disease involvement. Connecticut was the original state that started they're the state that really started screening breast ultrasound. There's a lady who basically had a delayed cancer diagnosis or a late stage cancer diagnosis, again, because she had dense breast tissue. And at this time, the general public just was unaware that this was even a risk factor or a problem with mammograms. They assumed, hey, my mammogram is normal, I don't have cancer. Unfortunately, she had treatment at that time, was cured of her breast cancer at that time, had a later recurrence of a myelodysplastic disorder, and actually recently passed away, and that was Nancy Capello. She was a lady that was kind of the strong advocate for making people aware of breast density. And again, that reinforces the idea that later stage cancers tend to have more aggressive treatment regimens, and the side effects tend to be higher as well. So again, we need to find ways to detect cancer early to have better outcomes, not only for the breast cancer, but the potential side effects from the breast cancer treatment. So this particular data was from Connecticut, and in their initial data, they picked up approximately 3 additional cancers for every 1,000 women screened that were not seen on mammography. And again, this is in the dense breast categories. There's been repeated trials that have been done in other settings, similar type of data. This particular Akron study had a higher incidence initially, and then it kind of leveled off to similar data to what Connecticut showed. So again, anywhere from 3 to 5 additional cancers per 1,000 women screened. The big downsides to screening with breast ultrasound is you have a pretty significant increase in recall rates. So in this particular study, there's 135 additional recalls for every 1,000 women screened. You also have increased biopsy rates, and those two result in a decreased, what we'd say, positive predictive value, or having more, for lack of a better term, false positives, where we see something, we work it up, it turns out not to be cancer. So while we are detecting more cancers, we also have more false positives. So there's the emotional stress that goes in with having a biopsy done, the cost that goes into having those biopsies done. So while this was a technological advance, it had some definite upsides, but there also were some limitations to the technology as well. This has brought us to the latest, greatest tool for breast imaging, and that's breast MRI. Breast MRI has been used as a diagnostic exam for women that are already diagnosed with breast cancer to look at the extent of disease involvement in the breast tissue, or women that have high-risk lesions that are prone to occur in both breasts. And also it's been used for screening women that are considered high risk. This is an exam that's typically covered by insurance for those high-risk patients, and it takes approximately 45 minutes. So that's been the big downside to breast MRI imaging up to this point is the time. So the longer the exam is, obviously that limits the availability of the MR. You can only screen or examine so many women when it takes 45 minutes compared to a mammogram, which takes 5 or 10 minutes to do. Plus, there's a significant cost with breast MR. It can be several thousands of dollars cost for the examination. Biggest reasons that women stated for declining breast MRI was there's obviously claustrophobia with being slid into the tube for the examination, time constraints, and financial concerns. So what we've tried to do with what I'll mention here in a second is trying to address some of those concerns, financial being a big one, and how to reduce time and claustrophobia that patients may experience during the examination. So what we've been doing here in Ames for about the last year or so is what's called abbreviated screening breast MRI. The main positive of this examination is that we're able to significantly reduce the cost. $399 is still costly, but compared to several thousands of dollars, it's obviously much cheaper than that. And we've been able to decrease the time of the examination to approximately 15 minutes. So we can screen 3 times as many women with this particular protocol as compared to the high-risk protocol. The unfortunate thing is this is not typically covered by insurance at this point. Maybe something in the future that is, but as of now, it's an out-of-cost expense for the patient. This is just a run-through of the benefits, again, of the different screening modalities. So obviously, mammography picks up a certain number, ultrasound picks up a certain number of cancers, and then MRI picks up a certain number of cancers. This particular study kind of isolated out the number of cancers that can only be seen on MRI. So you can see there were 31 cancers picked up on MRI, and of those, 14 of them could only be seen on MRI. So MRI is able to see the smallest cancers, and it doesn't have the inability to see cancers in women with dense breast tissue. We can basically see through that tissue and identify the cancers on MRI. The other big benefit in this particular study, there were no node-positive cancers, and you can see the overall median size of the cancers was the smallest on the MRI as compared to the other modalities. This is a couple examples of what I would consider the power of breast MR. So this first example is a patient that was not in a screening MR protocol, has dense breast tissue, which again we know obscures the detection of breast cancer. She actually subsequently underwent an MR examination, and if I look on this particular study, so this whole area here is what the breast cancer was on the MRI. So this is a sizable breast cancer. What we're able to do with breast MR is we inject contrast for the examination, and what we can do is actually look at the kinetics, the wash in and wash out of contrast into the breast tissue. So you see that red color scheme on there. That means very rapidly washing in contrast and very rapidly washing out contrast, and that's the typical behavior of what cancers look like. So again, if I jump back to this prior study, it is very difficult to pick up a cancer on here. The density of the breast tissue is totally obscuring seeing this cancer, even though it's a relatively several centimeter size cancer. This turned out to be an infiltrating ductal carcinoma. I'll show a similar examination. This was a woman, again, with dense breast tissue. She was undergoing screening breast MRI, so I will jump to the next image here. And you can see 2 images here. This is a non-color map image, and this is a color map image here. Again, seeing that red dot on the image here. that's a small cancer that we're able to pick up on MRI. So our goal, again, with MR is to pick up cancers that are smaller, like this size, and to prevent the later diagnosis of breast cancers like that prior example showed. So obviously that was a large cancer, but one woman was undergoing the screening MR that allowed us to pick it up at an earlier stage, while the other one was not undergoing the routine MR surveillance. Both of these turned out to be infiltrating ductal carcinomas. This particular study, again, compared mammography, ultrasound, and MRI. The most important part of this particular study that I want people to really hone in on is this sensitivity of MR. 91% of the breast cancers were picked up with MRI. That's pretty darn good. It's hard to get any type of test in medicine that gets 100% sensitivity, so this is greater than 9 in 10 breast cancers are picked up with MR. Mammography in this particular study was a little bit lower than what some of the other data shows us, but in this particular study, the sensitivity was only ranging between 30% and 50% for picking up breast cancers. So MR has a significantly higher sensitivity for picking up breast cancers. How do we identify high-risk patients? What we've recently instituted here in Ames are basically 3 models that we're calculating when a woman comes in for her mammogram. The GALE has been a risk model that you've seen for several years. The main benefit of that is it identifies a risk profile of patients that may benefit from prevention treatment, such as tamoxifen. And again, that's a 5-year risk of greater than 1.67%. The BRCA Pro assess for likelihood of mutation carrier status. And again, these are risk models that are generated by asking questions about family history and a lot of the other data points that I mentioned earlier in this presentation. The latest risk model that we're utilizing here is a Tyrer-Cuzick, and this is encompasses more data than even the GALE model does. So it takes more time for our techs to input all the information, but it's a more comprehensive risk stratification profile. The version 8, it's the first model that starts including breast density. So breast density is the newest risk that we've uncovered for breast cancer, and this model in the latest iteration is including that data in the risk model profile. How do we define high risk? With this latest model, we generally use a 20% cutoff, and that tends to be most insurance companies also follow that as a criteria point for stratifying people into high risk and low risk. That's important because they tend to pay for MRIs in that high risk group, while in the lower risk group they tend not to. As I mentioned before, this Tyrer-Cuzick model, the early data shows that it's the most accurate predictor simply because it's the most comprehensive model. Obviously, there's probably going to be other models that will come out in the future as our knowledge base evolves that'll be even more accurate, but this is probably the best method we have currently for risk stratification purposes. There are always harms of any type of screening program, whether it's breast, colon cancer. The biggest thing is the stress of false positives. Obviously, a woman comes in for a mammogram, gets called back. That can be a very stressful ride until they get either a diagnosis of everything's okay or you do have cancer. The other big thing is, are we picking up cancers that wouldn't ever harm the patient? So those low-grade cancers, the DCIS cancers that would never develop into a true invasive cancer. And then obviously with the screening programs, especially when you start including MRI, there's a substantial cost to doing those screening protocols. So again, it's trying to individualize this screening protocols as a way we can potentially less intensively screen women that are a low risk for cancer and more intensively screen women that are a higher risk cancer. So you potentially have the same number of dollars available to screen women, but just distributing that money more efficiently. Some of the other alternative screening options that are out there that you may have heard about. There are molecular breast imaging. Overall, kind of this type of imaging, I think several years down the road, this is going to be the way we probably detect a lot of cancers, is trying to find the genetic makeup of cancers and figuring out some type of isotope that can attach to particular cancers and really making it targeted both diagnostically and treatment. Big issues with this at this point is obviously you inject a radioactive agent, that exposure goes to the entire body. Also, how do you biopsy things that are picked up on this? We don't have a great way to biopsy things that are picked up on molecular breast imaging. And the lack of prospective trials showing, picking up cancers, does it affect outcomes, mortality reductions, treatment outcomes, those types of things. Contrast enhanced mammography is another option that's out there. And again, that's using the existing mammographic technology, but it's injecting a contrast agent as well. Again, trying to capture that rapid wash-in, rapid wash-out of cancers that would show up on a mammogram. Again, there's extra radiation exposure with doing that with mammography when you add the contrast portion of the study. And then again, we have limitations on how to biopsy things that are picked up with that contrast enhanced mammography. So both of these types of new screening modalities, they're promising, but they have significant limitations that aren't allowing us to roll them out on a widespread scale at this point. Thermography. The FDA just came out with a warning regarding this recently, that it basically boils down to, if you believe in evidence-based medicine, there's no evidence that thermography picks up any cancers. So we periodically get calls of people wanting us to partner with them with their thermography clinics, and we've just chosen not to do that just because there's simply no data that shows that thermography picks up cancers or has any benefit. So this is one of a million recent recommendations that have come out. This has just come out in the last couple of weeks. And basically, if I was writing what I would consider the best screening guidelines based on the available data we have, this particular algorithm is what I would use. So this is the 2019 guidelines. They just had their annual meeting, I believe just the beginning of May, and this was the proposal that they came out with at that time. What I'll do is I'll run through each step of this algorithm, and I'll also send out a PDF of all the recommendations after this, so you can have a PDF copy. And I think this is going to tie everything I presented together. It's going to encompass both the high-risk patients, low-risk patients, and really how we tailor the different screening options for individual women based on their risk profile. So the key number one question is, when do you start and when do you stop? What they're recommending is that women need to appear for a formal risk assessment at age 25. So this is jumping back up to 15 years earlier than where we typically start screening. And again, this is trying to capture those patients that may have a mutation that's going to make them much more likely to develop a cancer. And just using that Tyrer-Cuzick model, just asking many questions and figuring out what their true risk profile is, and then tailoring their screening based on that. When to stop screening, I like this idea. You can set an arbitrary number of age 75, age 85, whatever you want to pick. But in the end, it doesn't really matter. I think this is a more appropriate way. Do you think this particular woman has a 10-year life expectancy? If the answer is no, then you probably don't need to continue screening for breast cancer. If you say, you got an 80-year-old that's out running marathons, she probably has a greater than 10-year life expectancy, so she's somebody that should continue to be screened. So we'll categorize, we'll start with kind of the average risk women to begin with. So those are women that are, again, those category A and B, so those are the non-dense categories. So non-dense, average risk women, this tends to model what the radiology societies currently are recommending for mammogram recommendations, and this is the more traditional recommendation for mammography. So it's annual 3D mammography starting at age 40, no need for breast ultrasound or MR screening. So again, this is what I would say most people would traditionally say is what they're used to thinking about with mammography screening. Now you jump into average risk women, but this again is a category of dense breast tissue, so those are the C's and D's. So again, we're still recommending the same annual 3D mammogram starting at age 40. What we're supplementing is the consideration for adding MRI. And if you'll see our reports that we're generating here locally, that's reflected in our reports, where if a woman is categorized as CRD, we're not saying you have to have an MR, but we're saying, hey, you have dense breast tissue, this could be masking a cancer that's there. Go ahead and consider, moving forward with a MR. And it's a little bit easier to make that recommendation just because we do have that 15-minute exam that still is a costly exam, but we tried to make it more affordable and more available to more women by having it be that $399 cost instead of $2,000 or $3,000. Once we jump into the high-risk category, these are going to be both women that have the BRCA gene, or if they've had any type of breast radiation, or chest wall radiation for another type of cancer. And so in this particular age group, we're going to be starting MRI screening at age 25. So this is obviously 15 years ahead of what our typical screening parameters are. And then also adding 3D mammograms starting at age 30. And again, this is trying to detect those cancers that are going to be bad behaving cancers at an earlier, younger age. So this would be the other category of high-risk women. So it's those that don't have an identifiable mutation, but based on the Tyrer-Cuzick model, still are at that greater than 20% category. So based on family history, number of children's, all these other parameters that factor into that. So in these, we're going to be jumping back 5 years from what the typical initial screening is. So starting annual 3D mammograms at age 35. And then on top of that, strongly considering adding the MR supplementation. So again, this is not just those with dense breast tissue, it's all women in this high-risk category that they're recommending strongly considering the MR screening. This is going to be a little bit of a smaller age group, but yet nonetheless it's an important age category of women to look at. It's those that have already been diagnosed with breast cancer that have potentially had a lumpectomy. For those that are greater than age 50 that have non-dense breast tissue, again, that's that A and B category, still the recommendation at that point is going to be annual 3D mammography. Again, we don't have the difficulties with the obscuring cancers with the dense breast tissue, so the current recommendation is continuing just with annual mammograms in this population. Slightly different group. So again, this is those that have been diagnosed with the breast cancer, have had that lumpectomy performed already. We're subdividing that group into those that have had early age breast cancer, which is considered less than age 50, or those that have dense breast tissue. So early onset or dense breast tissue, we're saying 3D mammograms plus adding MRI on top of it. So the main difference is over age 50, non-dense, just stick with mammogram. Younger women, dense breast, add MRI into the protocol. Questions that people may have. Again, we'll have a summary of those recommendations because I really think that's the biggest stressor we've been putting on our primary care providers and other physicians is what the heck am I supposed to do these days? The recommendations are all over the place. I hope that summary will tidy that up a little bit.
When we do our screening mammograms and then they're recommended to come back for the ultrasound, at that time do we tell them in radiology, do we educate them on their consideration for having an MRI, or where does that come into play? Where do they learn about that?
Yeah, we have a pamphlet that we hand out to women both at the hospital here and at the clinic that kind of goes, it's basically an educational pamphlet that goes through what breast density is, what MRI is, what ultrasound is. So our techs are really good at trying to educate women as much as we can at that time. There still invariably are going to be questions that, again, fall back on the primary care providers, just because of that relationship that they have with the patient. So we try on the front end to educate patients as much as we can, but we realize that there's going to be other questions that pop up from the primary care to the primary care providers. So what we're trying to do is make those recommendations a little bit more streamlined, so providers can say, hey, here's the data, here's why we're making these recommendations, and here are your particular options that you have.
What is the plan for giving this information to our patients for McFarland, for this area? And will any of this be available on my chart?
Do you know, is any of it on my chart now? I don't think any of it. Okay. Right. Yeah, so our reports mention the breast density in them, so that's going to be accessible to the patients through my charts. A lot of the recommendations and things like that, those aren't included currently in my chart. But what we've got on our website for the radiology department is an algorithm that you can click to try to educate yourself on which category you potentially fall into. And it probably would be a smart thing for us to do is to include these latest recommendations on the website as well. We're doing community outreach activities as well. Dr. Lake just did a recent presentation in Ames, so we're trying to dispense the information in multiple ways through the radiology department, educating providers, and then doing community outreach as well.
Yeah, I understand where you supplement mammography with an MRI, but if you have a patient, for instance, a patient with a high-risk mutation, and you're already following that patient with yearly MRI, do you need to do a supplemental mammography periodically?
Sure. The current recommendations still say yes. I wouldn't be surprised if in the future we say, hey, MR is so good that we don't need mammograms. That still currently isn't the recommendation. The one particular cancer that has always been thought of as being less sensitive on MR is DCIS, ductal carcinoma in situ. Some of the early data is showing, though, that we pick up the high-grade DCIS on MRI and potentially don't pick up the low-grade DCIS, but may turn out that we're missing the quote-unquote unimportant cancers and we're catching the important ones on MRI. That's going to be an area of further research, which I could see that becoming a recommendation at some point, but it currently isn't.
And if you are doing both as screening, do you do those both at the same time each year? I remember a couple patients I had that had BRCA mutations. I'd do mammogram, and then 6 months later an MRI, and then 6 months later a mammogram, and just alternating those.
I've seen it done both ways, and it's a bit of a patient preference too. Some people like the convenience of just showing up once to get their MRI and mammogram. Other people like the reassurance of every 6 months I'm getting some type of screening done. I'm not aware of any data that says that one is dramatically better than the other. So a lot of it turns out to just be patient preference. There's not a right or wrong answer to that.
And just one last question: Are you doing MRIs at the clinic now, also in addition to the hospital?
Both locations.
Both places. Okay.
Yep.
I have a question about MRI leading to increased mastectomy rates. You know that most studies show this. And my concern is that if we are using it in not the high risk, but people just coming in and requesting an MRI because of their just personal anxiety, that we're going to have more patients that would have been able to be managed with breast conservation electing for mastectomy.
Yep. Again, I think that's a valid issue that's going to be brought up. Again, this full-fledged screening MR over a larger population is still a relatively new thing. So I think we're going to have to just look at what truly does happen. My guess is probably the mastectomy rates will go up, and that may be something where we have to tweak how we're screening women, or it may simply be an educational thing where the data will show at a certain point the outcomes of doing the mastectomy versus a lumpectomy. You know, the outcomes aren't any better, plus with the lumpectomy you don't have some of the side effects that you can potentially have with a mastectomy as well. So it's a completely valid point, and I think we just need to see where the data takes us. Thank you.